Hi folks, my name is David Villar and welcome to this presentation on basic mechanisms of non-steroidal anti-inflammatory drugs. A little bit about myself. I'm originally from Spain, did my master's at the University of Illinois, went on to do my PhD in Aberdeen with all the lovely Scottish people and scientists at the Macaulay Institute, and then went back to the US and did my residency in toxicology at Iowa State University. And for the past 12 years I've been teaching pharmacology at the University of Antioquia in Colombia. So in this first presentation I'm going to try to show you the way non-steroidal anti-inflammatories work in probably a very simplistic way. We all know how you can complicate things all you want in science and in the end get blown away and don't really learn anything. My problem is, as you will see, is that I tend to simplify things probably too much. So if we start with this simple scheme of an inflammatory process, we could say that an inflammation is basically a non-specific response of the organism when it's challenged with either a chemical, physical, or biological harmful stimulus that will cause tissue injury. So it's just the response of the body against any of these insults. And as you can see here, the five cardinal signs which are typical of the inflammation are heat, redness, pain, swelling or edema, and loss of function. And all these signs basically are a reflection of the local changes that are taking place in the local vessels, which are written here. And the two basic purposes of the inflammation are to fight or repel the insult, whether it's a foreign body or a toxin or a pathogen or what have you. And the second reason is basically to repair the damage on those injured tissues. So in this respect, you may wonder, why should we give an anti-inflammatory drug to stop the process which has so many advantages? Well, the reason being is quite simple. Inflammation does not come without some trade-offs. There are some disadvantages which are, for example, pain. Pain does not really serve any purposes beyond being just an alarm system. And once we know what the origin of pain is, the sooner we alleviate, the better for the recovery of the animal. The other problem of inflammation is that it in of itself causes damage to the tissues. Those neutrophils are not very specific in the way they work once they release those lysosomes to the damaged tissue. The other reason is that inflammation, if it becomes chronic, is very difficult to treat. And as you can see, another downside is the loss of function, which is another cost that you have to pay for having inflammation. Now, I don't want to give you the impression that it's a good idea to always suppress inflammation, because it's obviously a defense mechanism of the body against any type of aggression. And what I'm trying to tell you is that if you know what the aggression is, you basically attack or eliminate the aggressor with a specific treatment or therapy, and then you can just give the anti-inflammatory drugs so that you can relieve the body of those side effects that come along with the inflammatory process. If I had to give you the most important reason why we probably want to suppress inflammation, I would say pain would be number one. A constant pain creates a situation in the body in which is a kind of a self-perpetuating cascade of events in which the sympathetic nervous system is constantly overstimulated. The animal is under constant stress, in a catabolic condition, if you like, 24 hours a day. And the pain may go from being just nociceptive at the very beginning to being inflammatory and to become neuropathic, in which basically there are no mechanisms in which you can turn it off or switch it off. And when the pain becomes chronic, it's basically a disease in of itself, because the individual is basically unable to function and carry out its normal life. So to end the talking on this slide, there are two possible outcomes to an inflammatory process. The body is able to win the fight against the aggressor and is able to repair all the damage if the tissues are capable of regenerating, and then the inflammation disappears without leaving any traces, like if nothing ever happened. And the other outcome is when the body cannot eliminate the aggression, in which case the inflammation becomes chronic, and this is characterized by the presence of a scar tissue that replaces the normal tissue, and there is usually a permanent loss of function. If we look at this other slide, now we have inflammation at the very bottom of the graph, and everything on top is what I would call magic. I imagine it's all true because there are a lot of people which are much smarter than I am that have worked all this out and proved that when tissues are injured, those cell membranes get ruptured or released, and then the phospholipids are free to react with enzymes from surrounding tissues, and basically they convert all those phospholipids into arachidonic acid, which, as you can see here, it's further converted by other enzymes into leukotrienes and prostaglandins, and those two type of molecules are just two important type of inflammatory mediators which basically set up and continue that cascade of events in the inflammatory process. Now, as you can see here, the prostaglandins are just one type of mediators which the non-steroidal anti-inflammatories will suppress by inhibiting the enzyme cyclooxygenase, and the story could probably get much more complicated. From these graphs, I would also like to point out that when the cell membrane is injured, those phospholipids enter what is called the arachidonic acid cascade, and as you can see here, the glucocorticoids are probably the best type of anti-inflammatory drugs because they inhibit the phospholipase, which blocks the production of that arachidonic acid, and by doing so in such an early state of the cascade, basically you get a huge profound effect on the inflammatory response. They basically, it's not shown here, but the glucosteroids also suppress the responses of most of the white blood cells and other functions of the immune system. And if you were to do any surgery, that's probably why you don't want to use glucosteroids, because they basically suppress all the healing process and the regeneration of the tissues, whether it's the skin or whatever tissues you've been performing surgery. However, if we were to use non-steroidals, you don't really influence the action of the white blood cells, which, as I say, are crucial to clean up any debris and dead tissue that you leave behind during the surgery, and by doing so we don't really delay any repair of those tissues. Let's now say a few things about the prostaglandins, which as we said before are the target molecules that will not be produced when we give non-steroidal anti-inflammatory drugs. They're called autocoids, which are local hormones. In other words, these are hormones which are produced locally in just about any place throughout the body, and the target cells are usually present in the vicinity of the site where they are secreted. And now the most important thing that we should probably remember is that the prostaglandins, apart from having an inflammatory role, initiating all the cascade of events that we just mentioned, pain, fever, swelling, heat, and so forth, they also have an essential physiological role. Now, what's that role? Well, they have an essential role protecting the mucosal integrity of the stomach. Another role is protecting the blood perfusion in specific sites like the kidney. Another role is protecting, or well, I should say regulating the tone of the smooth muscle in the uterus. So we could say that all these are housekeeping duties of prostaglandins. In other words, they have physiological roles apart from the inflammatory roles. And you don't really want to abolish any of those roles, because that would result in side effects, or if you like, development of toxicity by the non-steroidal anti-inflammatory drugs. Now, is there anything we could do to prevent those side effects from taking place? The answer is yes. And I borrowed this slide from Dr. Ferguson. As you can see, the type of prostaglandins that are produced and which are essential for the body are synthesized by different cyclooxygenase. The cyclooxygenase 1, which is present in those tissues that I just mentioned, are usually produced at very low levels and are present in the GI, particularly in the mucosa of the stomach and the kidney, particularly in specific areas of the kidney, and also in the platelets. By contrast, the enzyme that produces the prostaglandins in really large quantities when there is an inflammation is the cyclooxygenase 2, and as you can see, this is usually present, it's not shown here, but is present in white blood cells, fibroblasts, chondrocytes, endothelial cells. And if we were to target this enzyme with a specific non-steroidal anti-inflammatory drugs that don't affect the cyclooxygenase 1, as we will see in another video, this is really a breakthrough discovery, a revolutionary discovery, because now we have really safe non-steroidal anti-inflammatories that we can give long-term, for example, for treatment like osteoarthritis in animals, and don't really affect essential prostaglandins in those other tissues. Now, the other thing that I wanted to show is this other picture, just to remind you that the most sensitive organ to the side effects of non-steroidals is by far and away the stomach. As you can see here, in a minute, prostaglandins, as we just showed, are crucial for the protection of the lining of the mucosa of the stomach against the gastric acid. And if we give non-steroidals and we take away that protective mechanism, you're basically going to make that stomach vulnerable to develop gastric ulcers, as is shown here on this slide. Now, how do the prostaglandins protect the mucosa of the stomach? That's shown on this other slide. As you can see here, basically the prostaglandins are essential to produce that protective layer which is on top of the epithelial cells, and that layer is rich in bicarbonate and mucus, and basically what it does is prevents the acid and the pepsin of the stomach to become in direct contact with the epithelial cells. And without those layers, the cells will basically be exposed to the acid. And as you can see here, aspirin and some other non-steroidals work by blocking that prostaglandin production, and it also prevents the bicarbonate production and the mucus layer production. We will also say in future videos that you don't really want to combine non-steroidals with glucocorticoids, because the glucocorticoids increase the production of the gastric acid and the pepsin, and by doing so, obviously, you're increasing even further the risk of developing gastric ulcers. Well, this was my last slide until the next video. So the idea was basically to show you some of the basic mechanisms of action of non-steroidals, how prostaglandins work. And so on the future videos, we'll talk about the pharmacokinetics of non-steroidals, and we'll say specific things about each one of those drugs. So until next time, take care, and bye-bye for now.